Good afternoon, everyone. My name is Dr. Jodie Guest. I'm an infectious disease epidemiologist, professor and vice chair of the Department of Epidemiology at Rollins School of Public Health here at Emory University. I lead Emory's COVID-19 outbreak response team and am the host for Emory's COVID-19 videos where we cover important topics about the COVID-19 pandemic. Today, I'm pleased to be joined by my colleague and friend, Dr. Carlos Del Rio, so that we can update you on the most recent information about the Omicron variant, as a lot has happened in the past 2 weeks since we last did a video. Dr. Del Rio is a distinguished professor of medicine, epidemiology, and global health at Emory and is the executive associate dean of Emory University School of Medicine at Grady Health System. While Dr. Del Rio has been recognized with many honors, yesterday he was named the Health Equity Champion by the CDC's Office of Minority Health and Health Equity. Congratulations, Dr. Del Rio. Welcome, and thank you for joining me today.
Delighted to be with you once again.
Thank you. Quickly, here's a look at where we are with COVID-19 across the United States. It has been a banner couple of weeks. Cases are up more than 254% in the past 2 weeks. On January 4th, more than 880,000 people tested positive for COVID-19 in the United States, with a 7-day average of over 550,000 new cases a day. To put this in perspective, this is 2 times our peak in last January and 3 times our peak from the Delta surge this past fall. 8 states currently have case rates that are more than 300% higher than last January, and only 5 states are not yet at their last January's peak numbers. 97% of the country is in the category of the highest category of community transmission. And while hospitalization rates are growing at a slower rate, we are now above what we saw in the fall with the Delta surge and up 51% for hospitalizations in the past 2 weeks. Death rates are still way too high, with more than 1,300 people a day dying in the United States from COVID-19. But this is still below what we saw last January and lower than what we saw in the Delta surge. Let's start today talking about the latest data on severity of disease with Omicron variant. Routinely, people are calling this more mild, and several studies around the world point to the idea that the Omicron variant causes milder disease than the Delta variant, including some new data on its impact on the lungs. But a quick reminder, even with a lower percentage of people needing hospitalization, with numbers more than double what we have ever seen for new cases, hospitalizations are still very high, hospitals are full, and this is scary for all of us. COVID-19 hospitalizations in the US have surpassed September's peak and are at 80% on the way to the peak from last January. So Dr. Del Rio, we're going to start there. With hospitalizations rising, were we too quick to say that Omicron is less severe, or is this a product of the sheer vast and massive numbers of COVID-19 positive tests that we are seeing across the United States?
You know, it's really complicated to try to tease this out, but let me try to give it a try. Clearly, the pathogenicity of the virus is determined. It tells you how severe the virus is, and I think this virus, this variant, is less pathogenic, less virulent than previous variants. You also have the host component, right? In the past, we had hosts with no immunity. Now we have a lot of hosts with immunity, with either vaccination or boosting. And while that vaccination or boosting may not be sufficient to prevent you from getting symptomatic infection, it's still pretty good to prevent you from getting sick. So let me tell you what's happening in hospitals. We have more patients than we've ever had before at my hospital, at Grady Hospital. But when I look at the patients, about 20 to 30% are people who are coming in with other diseases or in which COVID has exacerbated the other disease. So as a diabetic who's coming in with diabetic ketoacidosis, or as a person who had a car wreck, and because we test all the patients coming in, they're testing positive for COVID. So about 20 to 30% of the people have COVID, but they're not sick with COVID. They have another disease, and COVID happens to be an associated condition. You still have to isolate them. You still need to treat them as contagious individuals, and that's causing problems because you simply don't have enough isolation rooms to put those individuals. So sometimes you have to cohort them with another individual who's also COVID positive. Then you have about the other 70 to 80% of people in the hospital that we're seeing. About 80% of those, or 85%, maybe 90%, are unvaccinated. And those unvaccinated individuals are the ones that are having symptoms, and some of them are actually ending up in the ICU. They're not that many ending up in the ICU, but they are clearly, all of them are those individuals who are unvaccinated or who were vaccinated and non-boosted and have an underlying condition. That's the other group of individuals. So that puts up the whole spectrum. I would say that the percent of people who are in the ICU compared to previous surges is much, much smaller. I mean, we have the same number of people with COVID in the ICU we had right now when we had 80 or 90 patients, now that we have 250. So the percent in the ICU is much slower, but that doesn't mean that we're not getting overwhelmed. In addition to that, you have the problem that many in the staff are acquiring COVID in the community and therefore are calling in sick. So part of the problem that we have, for example, in ICUs is not necessarily lack of capacity because we don't have enough beds, but it's actually lack of staff to be able to take care of the patients appropriately who are in those beds. So it's a very complicated situation. The clinical presentation is also a little different. As we're learning more and more about COVID, this strain appears to cause a very different syndrome. And there's some laboratory data that suggests that this strain is probably not as good as it was previously to infect the lower respiratory tract. So you get less pneumonia, less severe, lower respiratory disease, but it's very good at infecting the upper respiratory tract. So you get more of a bronchitis or laryngitis or a upper, respiratory illness, very much like a head cold. You also get a lot of people complain of a tingling in the throat as part of their symptoms. And that's because, again, it's infecting the throat, the larynx, the upper respiratory airway. That would lead to more mild disease in adults. But in children, actually, that leads to fairly severe disease because children are not very good at handling upper respiratory infections. We see them get sick with influenza, with respiratory syncytial virus, and therefore hospitalizations in children are actually higher than they've been because children are coming in with what we call croup, which is this inability to breathe well. Now, the number of people hospitalized is still small compared to the number of people getting infected, but the number of kids in the hospital right now is higher than it's ever been, just because, again, sheer numbers. So you have a combination of a lot of people and then this very different pathogenesis of the virus. But what I want to remind people is this is not something that you want to get. So we need to, again, emphasize that the best thing you can do is not get infected.
I think that's so important. We don't probably spend enough time talking about longer term complications from COVID-19, and those exist. And those are a large percentage of people who get it. And so again, our best bet is to not get COVID-19. You briefly touched on the idea that there are some good data now saying that it's not affecting the lungs. So this is really different than what we saw previously. Are there any other symptoms that people are seeing different with COVID-19 from Omicron versus other variants?
As I said, more of a head congestion, sore throat. Interestingly, I've yet to see somebody with Omicron present with loss of sense of taste or smell, which was so characteristic in the past. I mean, you can almost make a diagnosis when somebody said, "Oh, I lost my sense of smell." That immediately meant it had COVID. I'm not seeing that with Omicron.
Okay, that's interesting. It would actually be easier if that was a consistent symptom because it is so unique.
Yeah, but it makes it hard, right? Because you don't know if they have influenza, they have COVID, they have another infection. So it makes it very complicated. It looks like everything else.
Yes, I can hear that for sure, especially as we've got cold season and the flu season upon us. Prior to Omicron, we saw that COVID symptoms could appear anywhere from 2 to 14 days. So this really protracted amount of time that symptoms could occur after someone was exposed to the virus. But some newer data is suggesting, some of this may be anecdotal, but some correlated data are suggesting that Omicron is speeding up this timeline and that most people who develop symptoms do so just a few days after exposure as opposed to a week or so after. In some ways, this feels like some good epidemiology data. There's less potential for asymptomatic spread. What are your thoughts on this faster timeline with Omicron?
Oh, it's very clear that the time between exposure and disease is much shorter. It's probably in the order of 1 to 3 days at most. A lot of people within 2 days. The challenge with that is that something we do in public health and we've been doing along, which is called contact tracing, simply doesn't work. You cannot do contact tracing for this disease. It just doesn't work. You don't do it. You can't do it fast enough, and therefore limiting transmission is incredibly hard. That's why we're seeing so much spread. And this is not the first time this happens. In measles, when we had measles outbreaks, you couldn't do contact tracing. It just doesn't work because it spreads so quickly. This is faster than measles. So So contact tracing is, at this point in time, I think, a waste of public health resources, because you simply cannot stop it, but you have to do other things, right? And that's when getting testing out and testing early is incredibly important, because if, I have a personal experience in somebody in my family who developed symptoms, tested, herself immediately that day, and was able to rapidly isolate and prevent infecting other people in her household. Nobody else in the household got sick. So you have to rapidly, at the first onset of symptoms, test yourself, and if you're positive, rapidly isolate to prevent infecting others. Because if you say, well, I'm going to hang around my house and get tested tomorrow, or wait, by that time, you probably infected everybody else in the house.
And it's kind of amazing, your story, because Omicron is so incredibly transmissible. What we're seeing is if one person in a house gets it, everyone gets it unless they are isolating really fast. Let's use this as a method to move into talking about the CDC guidance. Since we last talked, the CDC has put out new guidelines for isolation and quarantine, with some additional speculation that these would be changed on Tuesday of this week. First, let's go over the quarantine guidance. And this guidance differentiates by vaccine status. I'm actually going to show a picture because it is a little bit harder to follow without looking at a visual. So hopefully you're looking at that there. The guidance differentiates by vaccine status. So in one group, what we have are those who are not vaccinated or are 6 months past their vaccine series without being boosted. I think it's important to recognize in this blue box, it is putting together those who are not vaccinated and those who are 6 months past an mRNA series together in the guidance. And what it says there is, if you've had an exposure, you should quarantine in your home for 5 days and then test. And if you are negative, you should then be comfortable going back out into the public, as long as you adhere to strict mask guidance for an additional 5 days. If you're vaccinated and boosted, then you are in the strictly mask all the time when you're around another person for 10 days, test in the middle to make sure you're not positive, but there's no quarantine at home. And I'll give my personal anecdote for this. My daughter had an exposure on Sunday. She is vaccinated and boosted, and so she's now fully in a mask. She needed to be anyway for school, but she's now in a mask in our house as well. Ate dinner by herself last night, and we will test her on day 5. And because I had access to antigens, I've actually already tested her once. What are your thoughts on this quarantine guidance from the CDC?
I think it makes a lot of sense, because again, it really emphasizes the importance. The first time we see boosting playing a role. So it differentiates vaccinated from unvaccinated, and it also has a component of boosting. And again, it's saying what we all want to hear, which is, if you're vaccinated and boosted, you're more protected. You don't need to quarantine. And you are much safer if you're vaccinated and boosted than if you're not. I think the concern I'm beginning to have, and others are beginning to have, is how long will that boosting be good for, and how long will it help us to be boosted, right? But at least based on this guidance, I think it really emphasizes that vaccinated and boosted individuals are much safer than those that are not, and also are much freer than those that are not. And to me, that's a very important part of the guidance.
Great. Now, there's a test in the middle of this. What kind of test do you recommend here? Is this a PCR test that you want to be using here, or is this an at-home antigen test?
No, you don't want to do a PCR test, because PCRs will remain positive for a very, very long time. I think we first need to talk about, how do you make a diagnosis and what happens? So, I'm sorry, in this case, because of exposure, I think you could potentially do a PCR. That person hasn't been diagnosed. So if you really want to be absolutely sure, yes, do an antigen test. But I would, if I had access to a PCR at day 5, I would do a PCR, because again, Omicron exposure is very short. If you test positive, then you're positive. If you test negative, you can pretty much assure yourself you're not infected. So in this case, in after severe exposure, I would test myself. Now, I tell people again, we need to start talking about what is an exposure, right? And if you're wearing a mask, you're not exposed. That's the other component I tell, as a physician, whenever I see patients with COVID, I'm exposed, but I'm wearing a mask. I don't need to quarantine. I don't need to be, do anything extra. The problem here is you get exposed at home. And when you get exposed at home, that's when the transmission occurs. So if you want to be sure that if you are exposed and you want to be sure you got infected or not, at 5 days, if you can get a PCR, get a PCR.
Very good. Let's move to the isolation guidance. This is where we see a little bit more of a change from previous guidance and perhaps some more vocal concern about it. I'm again going to share my screen. This is in two parts that I'm going to show here. The newest guidance that came out on December 27th from CDC said that if you are asymptomatic, and I'll stress that word again, asymptomatic, after 5 days, you can leave isolation and then have 5 more days of strict mask usage in public. I think the caveat to being asymptomatic is not always well understood. And so we want to really, really recognize that. The other part of this was if you continue to have symptoms past day 5, you were to stay in isolation for the longer period of time, which had originally been 10 days. There was some hope in the public health community that the CDC would add a testing component to this. And yesterday we did hear from the CDC where they suggested that if you had access to a test, it was fine to do in the middle. And if it was positive, then you went to 10 days worth of isolation. If it was not positive, then you moved out in public wearing a mask. I want to talk about this guidance because you and I both have some pretty significant reactions to this. And you and I both really like the idea of if someone is no longer contagious to another person, being able to come out of isolation early. What do you think about this CDC guidance?
Well, let me start by saying that the reason for this change in guidance is twofold. Number one, clearly, we know more about the transmission of the virus, primarily among vaccinated individuals. And we know that even though vaccinated and unvaccinated individuals can both get infected, if you're vaccinated, at least with Delta, I'm not sure we have the data with Omicron, but I wouldn't think it will be any different. You clear the virus much faster. And it is only between the 3 and 5 and 3rd and 4th day that you're highly contagious. After that, it starts coming down. And by day 5 or 6, only about 20% or so of individuals are still contagious. The great majority are not. So that's the science told us that 10 days was clearly unnecessary. The second thing that it did is that, as I mentioned before, we are having a crisis with healthcare workers. And in order, if you tell every healthcare worker who's infected who has to stay home for 10 days, we would not have anybody to work in places like hospitals or in other critical industries. I'm talking about first responders. I'm talking about many other places where people are getting infected left and right. So how can you bring people back to work if they're feeling fine? And I think the key in this guidance is you need to be febrile and feeling fine. You need to be asymptomatic. If you're sick, it doesn't apply to you. But if you are asymptomatic, and I'll give you the example again of my relative, at 5 days, she was feeling totally fine. She was ready to get out of isolation. Now, she got tested with a rapid test. She was positive at day 5, positive at day 6, and on day 7, she was negative. So she came out of isolation at day 7. I still believe the testing was useful, was important, but honestly, if she was a required worker, if she had been a surgeon or an emergency room physician at day 5, if she was asymptomatic with a good quality mask, good fitting quality mask on her, she could have potentially gone back to work. She wouldn't pose a risk to her patients wearing a mask and not taking it off for any reason. And she could have done the work that needed to be done. So I can see why CDC said no testing necessary, because the reality is you can test positive for a little longer than your symptoms. You may be asymptomatic and still testing positive. And number two, if you're going to be in an industry that wears a mask all the time at work, that's really not a problem. But you have to tell people, you still need to wear a mask at home. And that's what CDC did. What I was not totally pleased is that, so I think the testing is, you can do it, you cannot. I'm in favor of doing the testing, but you could potentially say we'll remove the testing. But if you don't have it, you don't get it. But the part I was not very happy is the fact that they really didn't differentiate between vaccinated and unvaccinated individuals, because I do think there's a difference between vaccinated and unvaccinated individuals. And in fact, here at Emory, when we implemented those guidelines for our healthcare workers at Emory Healthcare, we actually sort of teased that out. We did a much clearer approach, and we said we have an approach for vaccinated and unvaccinated, and we have an approach for with testing and without testing. So if you're vaccinated and you can get a test at day 5, You can, if you're feeling fine, you get a test at day 6 and you can come back to work if you're negative. If you cannot get a test, you come back at day 7. If you're unvaccinated, then you can get a test at day 7, or you come back to work with no test at day 10. So I think being a little more nuisance about it, I think makes sense, because not everybody behaves the same way. Not everybody reports the same duration of disease and symptoms. And some people test longer for a lot longer than you would possibly think.
That was one of the things I wanted to ask you about. Anecdotally, I'm hearing from a lot of people who are still testing positive on it at home rapid antigen with Omicron past day 5 or day 6. Does this feel different, or do we not have any?
I think it's expected. I think a significant percentage are going to test positive at day 5. I tell people not to test themselves at day 5. I like the UK guidance. The UK guidance was actually issued before the CDC guidance. UK guidance cut the isolation from 10 to 7 days and said, get a test at day 6 and get a test at day 7. And then if you're negative in both, you can come out of isolation.
I agree. I love that guidance. Let's talk for a moment about antigen tests, because that's the kind of test that we really want to use if you're in isolation, different than a PCR test, which is super sensitive and is potentially going to pick up on some viral particles that may not mean you are infectious. So are we safe to use antigen tests to answer the question, am I infectious to another person?
Well, let me start by saying that the answer from CDC and from the FDA is going to be no. The tests have not been validated to do that. And that's part of the problem. So we're using them, but the reality is we don't know if that's a good indicator, right? I mean, I like to see the test being negative, but the reality is they have not been validated to do that. But we do know that a positive antigen test means that you have enough virus that could potentially be infectious. So from that, we can infer that therefore a negative test means that you're no longer infectious. I would still tell that person to wear a face mask for a total of 10 days. So the short answer is we don't have data to back that up, but that's the practice we're doing. And again, that's something that we do in medicine all the time. We don't have data for every single thing we do.
So there's a backlog of tests in the United States. It's hard to find an antigen test, and all of a sudden we see a lot of attention to them. Do you think we're going to start to use them this way, and we're going to start to say, hey, if I want to get together with a small group of people, they're all vaccinated, but we do want to be indoors and have a dinner party together, we should all use a rapid antigen before we get together?
I think so. I think that makes a lot of sense. We have to remember that these tests are not as sensitive as other tests. So my recommendation, if I got together, for example, with my family for Christmas, 14 people got together, we tested ourselves 24 hours before the event and immediately as the event was starting. So we did double testing. And if you do double testing 24 hours and then immediately at the event, the chances of finding somebody positive who's going to come in inadvertently, who's going to be infected and not be picked up by the test, dramatically decreases. So if you're going to do testing, you need to know how to do the testing. The problem that we have, again, I go back to the FDA. The FDA has no mechanism to approve this test as public health tools, which is how we like to use them. They still look at them as medical devices, and they look at them as diagnostic devices. And yes, they're not as good as PCR as a diagnostic test, but they're not being used in an effective way. And we need to learn how to use these tools as public health tools. That's what they are. And as public health tools, they're incredibly useful if you use them the right way. Now, I remind people that, again, a negative test is not a prevention measure. Yeah. And people have also confused that. The OSHA guidance recommendations for testing, for vaccination of employees said you can be vaccinated or you can be tested once a week. And I also don't like that because, testing once a week is not sufficient, as we talked about Omicron. And number two, testing is not a prevention intervention. I tell people that thinking about weekly testing as a way to prevent Omicron is like thinking about, doing a weekly pregnancy test as a birth control method. It doesn't work. It's a diagnostic tool.
Yeah, that's a good point. Let's stay with the FDA for a moment. Some very good news from the FDA came out on Monday, where the FDA expanded the emergency use authorization for Pfizer's COVID-19 vaccine booster to children aged 12 to 15. And the CDC is reviewing these data to make sure that they support it. Additionally, the FDA supported a booster for those 5 to 11 with underlying immunologic conditions. How important does this feel for kids and parents, especially as we want to work to keep kids in school, as long as it is a safe environment for both the children and their teachers and staff?
I have mixed feelings there because I don't think, again, we talked about kids not getting as sick with COVID. And we talked about kids, I think if kids are vaccinated, they're going to be protected. I worry that giving them a booster just to prevent them from getting infected is not necessary because they're not going to get sick. And especially if you're talking about young boys that have a higher risk of myocarditis, I really need to put in a balance the risk of myocarditis versus the risk of developing a COVID infection. And if they're already vaccinated, I'm not sure I've seen enough data to be in favor of boosters in kids that age.
Okay. All right. So the data also came out from Pfizer. This is a little bit ago. This was on December 17th. Pfizer announced that 2 very low doses of vaccine that they were testing in children under the age of 5 were safe. Great news, and had no severe events. The disappointing news was that the low dose that they were using did not generate a sufficient immune response in those aged 2 up to the age of 5, but did work in those aged 6 months to 2 years of age. Because of the way these trials are done, they're not going to skip and start vaccinating toddlers. Instead, Pfizer is moving to what they're calling their plan B, which is looking at a 3rd dose of this very, very low dose of COVID-19 vaccine for the 2 to up to 5-year-olds to hopefully provide an adequate boost to their immune response. Have you heard any updates on where we might be on these data and how long it might take to see how that works?
It's going to take some time, and maybe it won't take that long with Omicron around, right? And everybody getting infected. It may give us results very rapidly. But the reality is, again, that shows how clinical trials is done, and that shows how research is done. And that's, you have to take the positive results, but you also have to take the negative results. As somebody who's done HIV vaccine research for a long time, I'm very used to getting negative results. And that's part of clinical research. You have some wins, and you have some losses, and you need to, that's how research happens. And the right thing to do is to then look at alternative strategies and try to study them to try to get an answer. It's too bad. I feel bad because I would like those kids to be able to be vaccinated. But if it doesn't work, then we shouldn't do it.
Yeah, it's a very good point. And we've had so many wins with our COVID-19 vaccines. It feels different to have one that didn't work out so well, but it also shows that the system is working to make sure we're protecting everyone. Also new from the FDA this week, the agency shortened the time needed before receiving a booster shot for those who are 12 and older for Pfizer. Instead of needing to wait at least 6 months after your series was completed, now it's just 5 months. And on Tuesday, that CDC went ahead and supported and agreed with the FDA's decision. So first of all, for those who received a Moderna series, do they still need to wait 6 months to get a booster, or can they go ahead and wait 5 months?
It's again, right now it's 6 months, but the data is being crunched to tell us if 5 months is what you need to do.
Okay.
I mean, I really don't think it makes that much of a difference, honestly.
And do you think that this is very specific to Omicron, or is this based on just general waning immunity, or is this?
No, I think it's very specific to the fact that Omicron, I mean, clearly the data with Omicron, if you have 2 doses of Pfizer, your protection against symptomatic infection goes down to about 30%. And if you get a boost, it goes up to about 65 to 70%. So it really is a very Omicron specific issue. What I would love to see the company start working on is a broader vaccine, and more of a pan-coronavirus vaccine, because we cannot get out of this pandemic by boosting people. Israel is now giving a 4th booster, and I personally think that I feel really bad about us boosting ourselves 4th, 5th, 6th time, while yet millions of people around the world haven't even received their 1st dose. This is a global pandemic. We got to get people vaccinated globally, and we cannot continue using boosting this way, because this is going to be really increase health inequities, and that's something we need to really keep our eye on.
I fully agree. And that 4th dose in Israel, I'm getting a lot of questions about if we're moving that direction here in the United States. But as you point out, if I've now had a fourth dose of this vaccine and a large percentage of the world has had none, that is not equitable in any sort of fashion. Do you think that we are moving towards a 4th dose in the United States?
I hope not. I mean, what we need in the US is to get the people who haven't been vaccinated. We have about, 60 million, 70 million Americans who are yet to be vaccinated. We have to get those people vaccinated. The booster I need is for those that haven't been vaccinated to be vaccinated. The booster I need is for those that haven't been vaccinated globally to be vaccinated. That's how we end the pandemic. We don't end it by giving fourth and fifth and sixth boosters to people who already been vaccinated.
I agree with you. Let's wrap up with a prediction. When do you think, based on some of the data that we've seen in other countries, when we will reach our peak with Omicron and when we're going to start to see this slow down in the United States?
You know, I think, first of all, I caution people not to make a lot of extrapolations from South Africa or from England, because we were a couple of weeks later than England, and something called holidays was in the middle of that. So Christmas and New Year's is going to really increase transmission significantly. So I think that's going to change any modeling that you do based on what happened in other countries that occurred before that. So my prediction is that we're probably going to peak somewhere between the third week of January and the first or second week of February, and then we're going to start coming down from there. My concern, though, is that we're going to be having way over 1 million new infections over the per day over the next several weeks. So, you know, at this rate, we may actually really be able to reach, you know, herd immunity, because we're going to get so many people in the population infected that at some point in time, this may be sort of the beginning of the end of the pandemic, at least in this country, because Omicron is really going to infect pretty much everybody who hasn't been infected so far.
And while the numbers definitely point us in that direction, I want to reiterate something you said earlier that I fully agree with, which is our goal is still not to get it.
Oh, believe me, I don't want to get it.
Yeah.
Even though inside of my heart, at some point I say, you know, let's find a good time to just get it and get over it with, right? Because at the end of the day, you're going to get it one way or the other, I think, because there's so much COVID out there, and the economy's open. We're going to restaurants, you're going to shows, people are, you know, I mean, I don't see, when I look at people out there, it's not like people are taking precautions. And I just worry that most everybody has pretty much said, we're done with this. And that pandemic fatigue is really bad, because then people are not willing to mitigate. And we have to mitigate. We have to, in order to slow down transmission, we have to be part of that slowing down of transmission.
We want to slow down transmission, but we also want to slow down any new variants that are coming. And every single case of COVID-19, particularly among those who are unvaccinated, is a place where this virus can mutate further. And it would be great if Omicron was the last variant that we were to see from this virus.
I couldn't agree with you more. I mean, I think, again, as long as there's transmission, there's the emergence of variants.
Yeah, absolutely. Lastly, last question for you, masking. Have you changed your recommendations for masking? I am now completely in a KF94 every time I'm outside of my house. What do you suggest for people?
You know, I tell people to wear a mask that fits, a well-fitted mask. I like using, I have it looks like a surgical mask. It's a multi-layer mask. It fits very well. It's washable. I like using this mask. You know, I don't think you need to use a N95. A fitted N95 is simply very hard to use. But if your face fits well on a KN95, that's a good mask. Just be sure that it's a good mask, because if you bought them in the internet, there's a lot of face masks out there.
Absolutely. And I am gravitating towards the one that fits my face particularly well, and one that is easy for me to teach in and speak in without, you know, disrupting the way I sound. Dr. Del Rio, as always, it was such a pleasure speaking with you, and thank you for your guidance and your insight into what is going on with Omicron. For those of you who are watching, please keep doing the things that we know protect each of you individually, as well as those you love and those you live with and engage with daily. Please get vaccinated if you're not yet vaccinated. If you are vaccinated, please do get a booster. It will help protect you from Omicron. Wear a mask indoors when you're in public. There's almost nowhere in the United States where that is currently not called for. Remember that ventilation is important. If it is warm enough for you to be outdoors, that is a safer place for you to be when you're gathering. And do please recognize a very good place to be using antigens is right before you gather, as Dr. Del Rio suggested, in a sequential manner. Please, everyone, stay safe.